All right, we ready to get started? If you can hear my voice, clap once. If you can hear my voice, clap twice. Thank you. All right. Okay. And we're online? Okay. We're ready to get started, and we're really excited because we have our local team here who just got to drive right on in this morning from NIH. So we're really excited. We're going to have all of them speak over the next hour or so. But I did want to really thank Dr. Kelly Roszko, Dr. Gafni, Dr. Hartley, and Dr. Lionakis. Yes. All right. Very good. So welcome to the NIH team.
Great, thank you, and thank you so much for having us here. I think I can speak for us all that we love being able to be here and speak to you all. So it's great to see everyone in person, and I'm glad some people can join online. So as was mentioned, all four of us from the NIH are going to speak today, and we thought we would each give you our parts of the talk, and then we're going to stay up here as a panel at the end and have plenty of time for questions so that you can sort of ask all of us at the same time at the end. So I am going to speak about autosomal dominant hypocalcemia type 1 and go over some of the mechanism and the natural history of this disorder. And these are my disclosures. So first, I will start telling you a bit about normal parathyroid gland function, just to go over the basics there. And then we're going to talk a little bit about what is ADH1, the characteristics of ADH1 patients, and some complications that are specific to ADH1. So hypoparathyroidism, as many of you know, the main function of parathyroid hormone, or PTH, is to bring up your calcium in the blood. So there are 4 parathyroid glands, typically 4, that are located behind the thyroid, as you can see here. And I'm so sorry, I don't have a pointer, so you probably, what? Yeah, it just doesn't come out on the screen. I don't know if you see it. So there are 4 parathyroids located here behind the thyroid. And when the setting of low blood calcium, the parathyroid glands increase PTH secretion. And this acts in a couple main ways. First, PTH causes the release of calcium from the bone. And the bone is like a really large storage repository for calcium in our bodies. So that signal from PTH to give some calcium from the bone helps to keep our blood calcium in the normal range. Additionally, PTH acts at the kidney, and it tells the kidney to hold on to calcium and keep that calcium out of the urine. So again, sort of keeping more calcium to bring the blood calcium up. Also at the kidney, parathyroid hormone acts to increase the production of active vitamin D. So there's vitamin D and there's active 1,25-dihydroxyvitamin D, or calcitriol, as I'm sure you are all aware of. So parathyroid hormone increases the calcitriol production. And calcitriol goes to the intestine, where it increases calcium absorption from your food. So by all those ways together, parathyroid hormone is going to increase blood calcium levels to help keep them in the normal range. So how does the parathyroid gland sense calcium? Well, it does that through the calcium sensing receptor, or CASR. And this is just a picture of the receptor, because some of you might have heard of these parts of the receptor. And essentially, it's a large protein. There's an extracellular part, that means outside the cell, and that's the part that is, that's the part that's going to sense calcium at the top there. Then there's a transmembrane part, which kind of goes through the cell membrane. And then there's the inside the cell part, or intracellular. And that is the part that actually signals through what we call a G protein. So we call this a G protein coupled receptor. And it's that signal that signals to this cell to increase or decrease PTH production. So this is a calcium sensing receptor, and we'll talk more more about that as we go on, especially in ADH1. So the calcium sensing receptor is located in many cells throughout the body, but we really focus on the parathyroids and the kidneys. And in those two organs, the calcium sensing receptor is located in much higher numbers. So in the parathyroid cells, it's going to be sensing low calcium and then increasing PTH production and release. On the kidney cells, when it senses a high calcium, it signals that release of calcium into the urine. So if you can imagine here, the cell being sort of like a factory, there's this machine inside that's producing parathyroid hormone. And there's a really narrow range from 8.5 to 10.5 that we consider this normal serum calcium. We don't want to go too low. Obviously, you all know that. We also don't want to go too high. So really, the body needs to keep us in a range. And the calcium sensing receptor is here, detecting calcium and telling this machinery to produce PTH. So let's think of the calcium sensing receptor sort of like a thermostat in your house, right? So when it's cold out, the thermostat is sort of saying it's cold, turn on the heater and make heat. And in its really same analogy, you can imagine the calcium being low and the calcium sensing receptor detecting that low calcium and telling the parathyroid cell to make PTH. That PTH obviously then goes to the bone and the kidney and the 125 to the intestine, as we've all spoken about already, to bring up your calcium. So when blood calcium is low, the calcium sensing receptor is sort of turned down in activity and PTH production increases. Again, bringing up calcium. When the blood calcium is high, the calcium sensing receptor is activated, and that is going to decrease PTH production. As you can see here, the machine is sort of shut off by this signal. And you're not going to have this signal to increase blood calcium, so your calcium is going to start coming down. And about the calcium sensing receptor in the kidney, when this calcium is high, the calcium sensing receptor is going to tell the kidney to get rid of calcium by putting it in the urine. And so therefore, these people are going to have increased urine calcium when your calcium sensing receptor is sensing it. So now let's transition to talk about autosomal dominant hypocalcemia type 1 or ADH1. So ADH1 is a rare genetic hypoparathyroidism. The prevalence is about 1 in 70,000 people. And this is because of a change in the calcium sensing receptor, and that's causing it to be stuck in that activated state. So the body is really being tricked into thinking that the calcium is higher than it really is. So that's where this analogy of, the thermostat really comes in here. So imagining that it's freezing in your house, but the thermostat is sensing that it's 80 degrees and it just doesn't turn the heat on. And that's really what's going on in the parathyroid glands of these patients. So the blood calcium is low, but this activated calcium sensing receptor is reading that it's high, and therefore it's preventing PTH from being produced. And that's why patients stay in that hypocalcemic range. Similarly, things are happening in the kidney where these overactive calcium sensing receptors are sensing all this high calcium, even though it's not there, and they're excreting even more calcium in the urine. So patients have low blood calcium, but high urine calcium, and they're losing calcium in this method too. So in autosomal dominant hypocalcemia type 1, this calcium sensing receptor is signaling there's plenty of calcium, but patients have low blood calcium, low parathyroid hormone, high blood phosphate, and high urine calcium. And to summarize with this broken thermostat analogy, in ADH1, the set point is wrong and the receptor is too active, signaling that there's too much calcium when there's not enough, and thus PTH is not released. But what's important to remember for these patients is that these patients have developed normal parathyroid glands from birth, and the parathyroid glands are capable of making PTH. So it's not a problem with the gland can't make PTH. So there's no destruction of the parathyroid glands. They haven't been removed. They're there. They're just receiving the wrong signal. So finally, I'm going to go over some of the characteristics of patients with ADH1. And this sort of comes about from a recent study that we had done a few years ago. We noticed that there are a lot of gaps in knowledge about ADH1, and this is because it's a very rare disease. So there's many case reports and case series which talk about one patient here or two patients there or one family. But we felt there was a real need to tie all of this together to look at, a larger number of patients and see what was really going on with these patients. So we did a large literature search where we used all of these following terms of, ADH1, genetic hypoparathyroidism, et cetera. We searched for papers from 1996 to 2021. And then we collected data from each study. And with these search, we found about 70 papers. And we then went through each of these papers, pulled out as much patient data as we could, and collected that together to get a larger number of patients that we could look at all together. So we found that we had information about symptom onset in 183 patients. We had initial laboratory values in 90 patients. And we had information on the outcomes after treatment in about 58 patients. So first, let's talk about the inheritance of this. So we found that 78% of cases were inherited in a familial fashion. ADH1 is autosomal dominant. This means that it's autosomal means that it is on the normal chromosomes, not the sex chromosomes. So it doesn't have to do with X and Y and transmit differently if you're a man or a woman. It's just the regular chromosomes. And if you're dominant, means that if you have the gene, you are affected. And as you'll see when we go through, there's a really wide range of what symptoms look like in affected people. But the fact that you have one copy means that you have it, even if you have another normal copy from the other parent. And that was what autosomal dominant means. So each time a child is born, there's going to be a 50% chance that the child inherits this disease from their parent because of that autosomal dominant pattern. Then again, each time one of these children has another child, there's a 50% chance that that's going to get inherited. So 19% of the cases were found to be from de novo variants. And in these cases, the parents do not have ADH1. The siblings are not at risk for ADH1. The patient has acquired that change in their DNA just before or just after conception. So the patient is sort of the first person in this family to have this disorder. But then the patient then has a 50% chance of passing this down in the future because it will now follow that autosomal dominant pattern. And then for 3% of the cases, there was some type of unknown. They never found the genetics behind them. So how are patients diagnosed? Well, 70% of the patients were diagnosed because they had a symptom. Some type of low calcium symptom made them come to medical care. 24% of the patients were diagnosed because of family screening. And I will say it was striking to me as I did this study to see that, the inheritance, 78% of cases were actually familial, but only 24% were detected because of familial screening. And this could be for a couple reasons. One reason could be because, as I said, there's really variable what we call penetrance. So some people are severely affected. Some people barely know that they have this problem, and so it might have not been known as it was passed down. And the other reason is because the parents, one of the parent might have had idiopathic hypoparathyroidism, and thus, they didn't think the children were at risk, and no one thought to check the children or look at the children. So I think with this knowledge and with the increase in genetic testing over recent years, we can probably make this number better and sort of detect some of these children before they present with symptoms. And then 6% of the people had an incidental finding, which means they really went to the doctor for some kind of basic lab work and were found to have low calcium, even though they had absolutely no symptoms, and that was a surprise finding for them. The age of diagnosis varied widely. So the age of diagnosis of low calcium or hypocalcemia in general ranged from birth to age 66, with a median age of diagnosis of age 6. And that range for the actual diagnosis of ADH1 itself ranged even further, going all the way up to age 77, with a median age of diagnosis of age 25. So you can see many of these patients really weren't diagnosed until a little later in life. And then as far as the initial or presenting symptoms, 27% of the patients were initially asymptomatic, 33% of them had moderate symptoms, and 39% had severe symptoms, which would be seizure, laryngospasm, etc. And of note, the most frequent initial symptom was actually seizure in 38% of patients. And again, this is striking because seizures are very severe, and we really want to try to get these patients before they come to having a seizure, which could be life-threatening. And then the median age of diagnosis, as you would expect, was younger at 1.3 years in these more severe patients, but in these other less severe cases, it was 14 years. So you can see the severity changing really when they were diagnosed. Again, as you might expect, the more severe patients did have a lower mean blood calcium. You can see those more severe patients here in the dark blue. Their blood calcium was significantly lower than the asymptomatic in green or the moderately symptomatic light blue patients here. So urine calcium is an important feature that I do want to spend a little bit of time about. This graph shows in categories 1 and 2 patients with idiopathic hypoparathyroidism, and in columns 3 and 4, those are patients with activating variants in the calcium sensing receptor with ADH1. And you can see that this is before any treatment, that these idiopathic patients have low blood calcium and their urine calciums are pretty low. But because of that activation of the calcium sensing receptor in the kidney, these patients with ADH1 have a really high urine calcium despite the fact that they haven't been treated and their blood calcium levels are low. And you can see in this paper, too, that these patients are treated, and as their blood calcium goes up, which is on, it's not going to show up, on this x-axis here, is their blood calcium going up with treatment. Their urine calcium is going up quite dramatically as they get treated. So why does this all matter? Well, we worry about complications in the kidney, as you've already heard about. So, we found that complications in ADH1 patients increased as hypercalciuria increased. So this is the percent of treated patients who experienced complications. Before treatment, there were 34% of them having complications, but after treatment, 66% of patients were having complications. And these complications included kidney calcifications, which I just wanted to mention can come in 2 forms here. Kidney stones, which is called nephrolithiasis. And these are these stones that are located right in the tubes where the urine flows. And then nephrocalcinosis, which is actually calcification of the kidney tissue itself. And they would be the top 3 circles in that diagram of tissue calcification in the kidneys. So as far as complications, we define those as kidney stones, nephrolithiasis, kidney insufficiency, any type of brain calcification, although we don't think that these are quite clinically relevant, but we wanted to make sure we included them. And we found that in the patients who had normal urine calciums, there was 47% had complications, but in the patients that had high urine calciums, 88% of those patients had complications. So again, showing us that this urine calcium value really matters and is something that we have to monitor and to make sure that we follow and try to keep down to avoid complications in these patients. So sort of to summarize, in hypoparathyroid patients, urine calcium should be monitored, especially while on treatment and especially in patients with ADH1. High urine calcium can be associated with a greater chance of calcification, specifically kidney and brain calcifications. The majority of ADH1 patients have a variant in this gene inherited from a parent, and in most cases that is diagnosed because they present with symptoms. ADH1 patients have a wide spectrum of symptoms that range from asymptomatic to presenting with severe seizures. ADH1 can be diagnosed early in childhood or late in adulthood, and that's likely because of this large spectrum of symptoms. And the average calcium levels are lower in patients that have more initial severe symptoms. Treatment with calcium and calcitriol only cured symptoms in 69% of patients, which is data I really didn't have time to present today. Urine calcium tends to increase while on treatment, and these patients with the higher urine calcium levels generally had more complications than patients with a normal urine calcium. So importantly, this showed us that ADH1 patients could benefit from novel therapies, especially if those therapies don't increase urine calcium. And with that, I am going to move on to Dr. Gafni, who's going to tell you a little bit about what we have been up to at the NIH for this.
Thanks, Dr. Roszko, for a really great update. We wanted to give you a little bit more at the beginning because we know we're one of the earlier talks, but everybody here is going to hear more, and some things will be more personal for you. Just waiting for my slides to show up, sorry. But it's great to see everybody. It's been years since we've been together in person, seeing a lot of old friends, people who have been at the NIH, since I was a fellow back in the 90s, so it's really great to be together again. Okay, here are my disclosures. So I think everybody here knows conventional treatment of ADH, which Dr. Roszko just discussed, calcium in multiple divided doses during the day, vitamin D with or without calcitriol. Some patients also need extra magnesium. But treatment is problematic because, as you heard, we still are targeting the blood calcium levels below the normal range, so patients often still have symptoms. And this increase in urine calcium can lead to these calcium deposits in the kidney. I won't go over this slide again. Dr. Roszko just discussed it in detail, but the bottom line is when patients with ADH1 tend to have higher urine calcium even before treatment, and then when you take calcium and calcitriol, the urine calcium will go even higher. So we're constantly walking this treatment tightrope where we want to keep the blood calcium high enough so the patient's not having a lot of symptoms, but we also need to keep the urine calcium down to prevent those complications. So there are some additional strategies to reduce urine calcium, and I'm sure you're all familiar with this. Drink lots of water. We tell all of our patients to drink lots of water, so hopefully you all have water on your table. We're not inspecting, but reduce your salt intake. So we don't have the salty snacks out. It's candy from Halloween. But and then some patients are treated with thiazide diuretics to reduce urine calcium. This is not that well studied in either hypoparathyroidism or ADH and can lead to other electrolyte problems. So if you're taking hydrochlorothiazide, you have to be mindful of several other things, especially the low salt intake. So what about using parathyroid hormone in patients with autosomal dominant hypocalcemia? We're all familiar that there's two flavors of parathyroid hormone that have been out there approved by the FDA, PTH 1 to 34, which is also called teriparatide and was approved for osteoporosis. And then there's TransCon PTH, which you're going to hear more about during this meeting, that's still under investigation, not FDA approved yet. And then the full-length PTH 1 to 84, this refers to the number of amino acids in the molecule. Parathyroid hormone is an 84 amino acid hormone, but the first 34 amino acids is really where the biological activity resides. So that's why you can use either the small fragment or the full-length fragment. And this PTH 1 to 84 is intact parathyroid hormone, which, as I'm sure many of you know, was approved by the FDA and patients were receiving it, but it was discontinued due to some formulation issues. So the thing about patients with autosomal dominant hypocalcemia is that PTH therapy has not really been well studied in this specific patient population. It's really only been studied in small groups of patients with ADH, and both through intermittent injections and continuous pump therapy. But in fact, patients with ADH were specifically excluded from most of the large studies that led to FDA approval of parathyroid hormone for the treatment of hypoparathyroidism. And while short-acting PTH injections can manage blood calcium, they don't completely normalize 24-hour urine patterns and can still have unintended effects on the kidney and the bone. And so, for example, this is the baseline kidney ultrasound on one of my patients with ADH1, an activating variant of the calcium sensing receptor, who was on a PTH study. So this is his kidney ultrasound before PTH therapy, and it's a little hard, I don't have a pointer to appreciate it. The white stuff in the middle is normal, and then the black area around it, it should be black. There's no nephrocalcinosis or calcium deposits, but you can see after 1 year of parathyroid hormone in this adult man with ADH1 that he did develop calcium deposits even though he was on PTH. Probably the longest known exposure to PTH in somebody with autosomal dominant hypocalcemia is this woman who at 20 years of age, she had been already treated 14 years continuously with PTH 1 to 34 injections twice a day, but despite this treatment, her urine calcium remained elevated, and while she had no calcium deposits when she was 6, she had extensive nephrocalcinosis by age 19. Her bone turnover was higher than normal during this treatment, and her spine and hip bone density became quite increased on treatment, while her forearm bone density became decreased. And so this is just a picture to show you that twice daily PTH injections can have these unintended effects on the skeleton. This is the head CT of this woman when she was 18, and her skull is quite thickened, and there are these patchy areas of increased and decreased bone, sort of these black areas where there's less bone, and then these very white areas where there's more bone. And just to give you a comparison, this is the head CT of an adult man with ADH1 who's not been treated with PTH. So clearly, this is not really a physiologic replacement the way it's been done with this PTH 1 to 34 twice daily, but maybe using longer acting PTH analogs will better replicate the typical 24-hour profile, and you won't have these effects on bone. But specifically in patients with ADH, PTH therapy won't affect this overactive receptor in the kidney. So better treatments for ADH are needed, and I like to show this timeline for parathyroids in general. Parathyroids were first identified in the late 1800s in Europe, and really these were the last anatomical structures to be found because they're so small. And back in the early 20s, up in Canada, the same group that was developing insulin, they gave parathyroid extract to a dog who'd had the parathyroids removed. PTH was then isolated in the 50s, and as you heard earlier, in the 1990s, we were using PTH 1 to 34 extensively in studies at the NIH. PTH 1 to 34 was approved for osteoporosis in 2002, and then 1 to 84 was approved for hypoparathyroidism in 2015, only to be recalled in 2019. But what about ADH? So the calcium sensing receptor was identified in 1992, and it was within a couple of years we were recognizing that variants in this receptor were the cause of ADH. And then in 2000, a class of drugs called calcilytics came on to the scene. So what is a calcilytic? These are a class of drugs that turn down the calcium sensing receptor, essentially resetting the thermostat. And they make the parathyroid cells and the kidney cells less sensitive to the blood calcium levels. And this results in an increase in PTH secretion and less calcium lost in the urine. And the drug was actually developed as a treatment for osteoporosis because you guys know hypoparathyroidism is a rare disease, so people want to develop drugs for common diseases because that's how companies make money, right? So anyway, this was developed and it was given to over 1,200 women with osteoporosis, and what they saw was that this class of drugs increase the blood calcium and the parathyroid hormone levels in these women, but it didn't help with the osteoporosis, so it was sort of abandoned as a treatment for a common disease. But the safety profile was very good. So what we looked into was the repurposing of these existing drugs for this specific disorder, ADH. So again, how would a calcilytic work in a patient who has ADH, who has this activating variant? So again, you saw this picture, this calcium sensing receptor is stuck in the active state, telling the parathyroids there's lots of calcium around, don't make PTH. And so when you add this calcilytic and you reset this receptor, now it detects that the blood calcium level is low and is able to start producing PTH appropriately. And then the blood calcium level responds by going up. And similarly, you have the same issue in the kidney where this activated receptor is telling the kidneys lots of calcium around, pee it all out into the urine. But when we apply this calcilytic, now we're resetting the signal so the receptors in the kidney can respond appropriately and decrease the amount of calcium in the urine. So there have been some animal models of ADH1, and these animals have been treated with calcilytics and saw an improvement in blood calcium and a decrease in urine calcium. And so we were very excited about the prospect of doing this. And back in 2014, we did a small study at the NIH in collaboration with a pharmaceutical company. And this was the first administration of a calcilytic to an individual with ADH1 in 2014. And this small study of giving the IV calcilytic to 5 individuals with ADH1 suggested that this class of medicine might work in people. So we were very excited. We wrote a new protocol. We were going to do higher doses for longer duration. But then, as happens in business, that pharmaceutical company was purchased by another pharmaceutical company who was no longer interested in pursuing this drug development. So basically, we at the NIH, especially Dr. Michael Collins, who many of you know, talked to anybody who would listen, who had a pharmaceutical company, and said, hey, we've got this great idea for a drug with this disease. Would you be interested? And finally, we developed a partnership with BridgeBio and subsequently Calcilytics Therapeutics to develop this oral calcilytic called encaleret. And that led to this phase 2 study, with which many of you are aware of because we've been presenting a lot of information lately. It's a phase 2b open label study divided into 4 periods. The first 2 periods were brief inpatient stays where the doses were adjusted and escalated, where we were trying to figure out the best dose. And then a 24-week outpatient period in period 3. And this recently was just, the results up through period 3 was just published in the New England Journal of Medicine in September, which is really exciting to see our hypoparathyroidism research in such a prominent journal. And then a long-term extension phase with data out to 12 months and even longer. And our main goals were to see, is this drug going to be safe? And then to figure out the best dose that will increase and stabilize PTH levels, increase and stabilize blood calcium levels, decrease urine calcium, decrease and stabilize blood phosphorus, and increase and stabilize blood magnesium without taking any oral supplements. So the goal was, can we use this drug, no magnesium, no calcium, no calcitriol? These are the baseline characteristics of our patients. We had 13 patients with a mean age of 39. 62% were women, and their labs were consistent with what you might expect. They had low calcium and low PTH. They had highish phosphate and lowish magnesium. They had inappropriately elevated urine calcium, and about 3/4 had kidney calcifications on ultrasound. And their kidney function varied from mild to moderate, renal function decreased to normal. And they were all on calcium and calcitriol supplements in divided doses throughout the day, and there were 9 different calcium sensing receptor variants in this population. And then September 28th, 2020, we gave the first dose of this oral calcilytic to an individual with ADH1, and you can see members of our team there. And this patient, who's in her 20s, I've been taking care of her since she was 5 years old, so this was pretty exciting for all of us. So I'm going to just show you a few graphs with the results of this data. They're all structured pretty much the same. The first 4 points on the left are from that period 3 24-week period, and then on the right you see 12 additional months of treatment. So this is going to be treatment over 18 months. You can see in the top graph that the parathyroid hormone, which was very low at baseline, pretty much immediately went into the normal range and stayed in the normal range over this 18-month period. So as Dr. Roszko said, people with ADH1 have normally developed parathyroid glands. They're just getting the wrong signal. And more importantly, the blood calcium level shown here, which was very low at baseline, almost immediately went into the normal range and was maintained over 18 months. And this corresponded to a decrease from an elevated urine calcium also into the normal range that was maintained over 18 months. And there was no progression of renal calcifications on ultrasound seen at the end of that 24-week period or again a year later. Blood phosphate is shown at the top, and that decreased and stayed in the mid-normal range, and blood magnesium in the bottom increased and stayed in the mid-normal range. And what was really interesting about these 13 people was that their dose requirements were really, really different. So what you're seeing here is a line for each patient of what their dose requirements were over that 18-month period. And the dose was given twice a day. So the total milligram dose that you see on the side is the total dose for day, which we divided into 2. But the requirements were really different. So one patient required 5 milligrams twice a day, and another required 180 or 190 milligrams twice a day. But once we got them to the dose that worked for them to keep that calcium in the normal range, they really didn't change much. And again, we were not targeting the calcium to the low normal. We were targeting calcium to, just the regular normal range. Bone turnover is still an open question. Remember, patients with hypoparathyroidism of all types have low bone turnover because PTH is what's needed to turn bone around to make it be kind of broken down and built back up again. So it's not unexpected that bone turnover markers would increase when the parathyroid hormone level goes high. In most cases, these stayed within the normal range, but there were a few patients who really bounced around and were above the normal range, and we're continuing to monitor that. But importantly, when we looked at bone density by DEXA scan, we really didn't see significant short-term effects on bone density at screening compared to period 3, and then even a year later. Encaleret was very well tolerated with no serious adverse events reported. So what I'm saying here, no serious adverse events. No patients during this entire study have had to go to the hospital for an IV calcium infusion. Nobody's had to be admitted to the hospital overnight because they had a gastrointestinal illness and they couldn't keep their medications down. Nobody. And this was during COVID. We did this whole thing during COVID. Patients had COVID. Nobody had to go to the hospital. It was amazing, really. The only little treatment related adverse events was some transient drops in blood phosphorus or transient increases in blood calcium while we were adjusting the dose. But again, nothing severe, and they were all asymptomatic events. So what's next? You're going to hear a little bit more about some other studies that Dr. Hartley is doing, but Many of you are probably aware that there's now this multi-center international phase 3 study underway. It's called the Calibrate study. At the bottom, it lists a lot of the sites where this will be taking place. There's a lot of sites in the United States. You're going to hear more about this tomorrow from Dr. Mary Scott Roberts at Calcilytics. Now, I'm a pediatric endocrinologist, so of course, I really want to see trials in children and pregnant women. And just to sort of end on that, this is one of my patients who's enrolled in the Encaleret study. You can see how low her calcium level was in period 2, where we were adjusting the dose, but once she got into period 3, her calcium levels have pretty much stayed within the normal range. In contrast, I also take care of her son, who's on calcium and calcitriol. And he really bounces around a lot. And even just this past week, he had a gastrointestinal illness, vomiting, unable to keep his meds down, having to go to the ER, getting IV calcium. And I'm still waiting for my nurse to text me his labs from today because I'm still adjusting his medications now a week later. So to conclude, I think you know about the calcium sensing receptor and the issues with conventional treatment. And that PTH wasn't well studied in ADH1, but that these calcilytics may become an effective oral therapy for patients with ADH1, and ongoing studies in adults and future studies in children are necessary. And really, this is some of our group, but the most important people in this are you guys, the people who participate in these clinical trials that help not only you, but future generations, particularly in the genetic conditions. So I just want to thank everybody very much. And I'm going to throw it now to Dr. Hartley, who's going to talk a little bit more.
Thank you all for coming and inviting me here. I'm just going to wait for my slides to show up. Oh, okay. Oh, how do I go back? Okay. Hi, so I'm Iris Hartley. I'm a endocrinologist, adult endocrinologist at the NIH, and I'm going to introduce to you a study that we are currently recruiting for and working on. We're going to explore the use of calcilytics as a potential treatment for post-surgical hypoparathyroidism. Dr. Gafni just talked about using calcilytics in ADH1, but we're going to explore whether this could work in other forms of hypoparathyroidism. Here are my disclosures. Okay, so I first want to introduce a kind of visual analogy to the way calcium works in the body. And I think that it's very hard to understand calcium balance, and I'm a very visual person, so I just want to share this analogy to you guys as a way of thinking about how calcium is balanced in the body. So I call this my bucket analogy. So there's a bucket full of water. There are faucets at the top pouring the water in, and there are holes at the bottom. It's a leaky bucket, so there's holes at the bottom allowing the water to come out. So in the analogy, the calcium that's coming, the water is calcium, and it comes into the body through only one way, through your diet and absorption by your gut. That's the only way you can get calcium into your body. It only leaves in one way as well, and that's through leaky kidneys and leaving through your urine. So there's only one way in and one way out, and the level of the water in this bucket is your blood calcium level, okay? So if you increased your dietary calcium, your blood calcium might increase, and if you were able to increase urinary excretion, your blood calcium might decrease. So this example, this first bucket, I'm going to show you a bunch of different ones, is representative of a person with functional parathyroid. So they have good gut absorption because they have high levels of calcitriol made by production by PTH. Supports calcitriol production, so they're absorbing all the calcium they need, so there's good intake, and they have a normal level of urinary calcium excretion, and their blood calcium is normal, so it's right up to the top. That's in contrast to the situation in hypoparathyroidism. So in hypoparathyroidism, your calcitriol is low, You can't raise it because your PTH is low. And so you can't really absorb, even if you're eating a normal amount of calcium, you can't absorb all of that calcium in your diet. So the calcium in is low. The other thing that happens in hypoparathyroidism, the parathyroids are really important at the kidneys to hold on to calcium. And so the kidneys are more leaky than they would be in somebody with functional parathyroid. So you can see there's 3 holes there instead of 2 holes in somebody who has functional, your kidneys are a little bit more leaky, so they lose more urinary calcium. So both of those things combined result in what we see in hypoparathyroidism, a very low blood calcium level. So as many of you, I'm sure all of you are aware, experiencing low blood calcium can be very unpleasant. People are very symptomatic. There's numbness, tingling, and when very severe, there's a risk of tetany and seizures. So there are 2 different methods that you could use to increase this blood calcium, or increase the water in the bucket. The first thing you could do is just pour as much water as you can into that bucket to fill it, right? If you just, dumped as much water as you could into that bucket, you could get the level to raise no matter what, if there's a leak in it, right? That's one way you could raise it. The other way is by repairing the bucket and making it not leaky, right? Those are the 2 potential ways of raising blood calcium. So the first way is what we do with what we call conventional therapy with calcium and calcitriol. So we increase calcium intake and we increase calcitriol, and calcitriol is important for the absorption of calcium. And both of those things result in a really high level of absorption of calcium, and you're basically dumping calcium into the system, which is great because people feel better, their blood calcium goes up, and I think that's one positive. But the negative is you can see that the leaky kidneys are dumping all of that calcium into your urine. And we know that the side effects of that are kidney stones, nephrocalcinosis, and kidney injury. So this is obviously not an ideal situation either. And so that's why we have that very careful balance that Dr. Gafni mentioned in all patients with hypoparathyroidism, where we're trying to maintain a blood calcium level that's just high enough that patients aren't having unacceptable symptoms, but low enough that their urinary calcium is not so high that their kidneys are at risk. So that's what we currently are doing. But we want to consider, what if we target something else? We don't just dump calcium into the system, we target the leaky kidneys themselves. And so what would that look like? So if you plug these leaky kidneys and make it so that they're not losing calcium into their urine, what happens? So 2 things happen. One is that you have decreased the amount of calcium that can be excreted, and so the urine calcium goes down. And the other thing that happens is, you have the same intake of calcium coming in, and so the level of the blood calcium potentially could increase. So Dr. Gafni presented these with a prettier slide, but there are current strategies to target urinary calcium and reduce urinary calcium losses. And the main 2 right now are to decrease salt. So salt takes calcium with it when you pee it out. So if you have a low salt diet, that will decrease urinary sodium and also decrease urinary calcium. So that's one strategy. Thiazide diuretics, though not well studied in hypoparathyroidism, can be effective in some patients with mild hypercalciuria to decrease the amount of urinary calcium. It works, it's more effective in conjunction with a low salt diet, but it does cause low potassium in some patients, and particularly if you have a baseline low blood pressure, it does decrease blood pressure, so that can be problematic. You can also decrease your risk of having calcifications by increasing fluid and water, although the amount of calcium in your urine is still the same, but the risks are much less because you've diluted that calcium. So in my study, we are wanting to think about this new strategy, targeting the calcium sensing receptor in the kidney. As Dr. Gafni mentioned and Dr. Roszko mentioned, the calcium sensing receptors are found in both the parathyroids and the kidney. And calcilytics work by turning down this calcium sensing receptor. And they really make the parathyroids in the kidneys try to target a higher calcium level. And so if you give a calcilytic, the parathyroids in the kidneys want to increase their calcium, and it does it the way they know how. So parathyroids increase PTH, and the kidneys hold on to all the calcium and prevent it from being lost. So it's kind of like a plug in the leaky kidneys. In clinical trials, calcilytics have been used in postmenopausal women. They increase the blood calcium, increase PTH, and decrease urinary calcium. And Dr. Gafni just presented in autosomal dominant hypocalcemia, where they have overactive calcium sensing receptors. This basically reverses their problem and does the same thing. It increases blood calcium, increases PTH, and decreases urinary calcium. But up to this point, it's only been given, or all calcilytics have only been given to patients with intact parathyroid glands. So the question still stands, would it work in people who don't have parathyroid glands with post-surgical hypoparathyroidism or other diseases where their parathyroid glands are not functional? So I think this is particularly relevant because post-surgical hypoparathyroidism is the most common cause of hypoparathyroidism. 3 out of every 4 patients who have hypoparathyroidism have it due to a previous surgery. And post-surgical hypoparathyroidism is a rare consequence of neck surgery. You can see these parathyroid glands are right on the back of the thyroid. Some of them are actually embedded in the thyroid. So you can imagine if you're removing like the thyroid, it can be potentially difficult to not damage these tiny organs. So what do we need to consider when thinking if calcilytics would work without parathyroid glands in the neck? Because we mentioned in ADH1, they have parathyroid glands. They're just not working properly. In post-surgical hypoparathyroidism, patients have little to no parathyroid tissue. So we don't think that if you stimulate parathyroid tissue that's not there, it probably will not produce extra PTH, right? Because the parathyroid tissue is just not there. So I think PTH is unlikely to increase in people with post-surgical hypoparathyroidism. Obviously, if somebody has a little bit of tissue, it's possible that it could increase, and we're really interested in knowing the answer to that. But I think that that is probably not going to be the main effect of calcilytics in these patients. We believe that the main action will probably be on the calcium sensing receptors that are found in the kidney. And giving calcilytics to people with post-surgical hypoparathyroidism will be kind of like plugging the leak of the kidney to decrease urinary calcium losses. In animal models of animals who had parathyroidectomies, calcilytics have been shown to increase blood calcium and decrease the urinary calcium. So that brings me to the study that is currently ongoing at the NIH, where we're going to look at the use of encaleret, which is the calcilytic used in those ADH1 patients that were just presented, in people with post-surgical hypoparathyroidism. Sorry, can you click the next slide? I don't know what happened, sorry. So this is the study design. It's a very small proof of principle design. We just want to make sure that this works before we do something that involves dose finding and long-term treatment. This involves up to 15 adults with post-surgical hypoparathyroidism. We're enrolling up to 10 people who had surgery greater than 1 year ago and up to 5 with surgery less than 1 year ago. And the reason I'm including those patients who more recently developed hypoparathyroidism is because, one, I think that is the most symptomatic year often for patients. I think that is a really important time that we should try to offer therapy to patients. And the other reason is, there's an open question. If somebody has a slightly injured parathyroid, would stimulating it help increase their ability to produce PTH? Participants have to be in generally good health and not be on either PTH or another investigational drug, just because we want this to be a very clean study where we really truly find whether this drug works. And the study is located at the NIH Clinical Center, not far from here in Bethesda, Maryland, and travel and lodging costs will all be paid. So this is the design of the study. It starts with a screening visit. This is an outpatient visit at the NIH just to assess eligibility. Patients will have to stay at an overnight near the NIH, and that's really just to do a 24-hour urine. Otherwise, it's just a one-day visit with blood work, kidney ultrasound, and EKG. That will be followed either directly after or whenever is convenient by an admission visit. It's a Saturday to Saturday overnight stay at the NIH Clinical Center, and participants will be given oral encaleret twice a day for 5 days. After they're done with after those 5 days, we'll stop encaleret before they go home, and during the admission, they'll get frequent blood and urinary sampling, 24-hour urines, and EKGs. Once they leave the NIH, we have one lab follow-up just to make sure that going back to their regular therapy, that there were no changes or any concerns. And we'll be calling several times afterwards to make sure everybody feels okay. So what potential risks does encaleret have, given what we know and our experience with it in other patients? So there's the possibility, if we start encaleret, that patients may develop a high blood calcium. And that, in some ways, is a desired outcome because we are hoping to show that encaleret will increase blood calcium. It's also possible that patients will have a low calcium if encaleret doesn't work, right? Because we might be giving them encaleret and it just doesn't work. And there's this very unlikely possibility because low phosphate was something that occurred transiently and asymptomatically in the ADH1 patients. That is also a possible risk, although I think it's very unlikely because the cause of that low phosphate was due to very high PTH levels, which I don't expect in this population. And there were no other specific safety signals in both the osteoporosis or ADH1 studies. And to make sure that this is done safely, this is why during this study we're having patients be inpatient, where they can get immediate either extra calcium, we can stop the drug, we can give them fluids, and we're frequently monitoring and making adjustments to the calcium or calcitriol when needed. Our primary objective is to try to determine if encaleret can increase blood calcium while decreasing urinary calcium in post-surgical hypoparathyroid patients. We would also like to determine how many patients we can get to achieve both a normal blood and normal urinary calcium together. And we also have a lot of exploratory objectives to try to see if this study can teach us more about how the body uses calcium, what the role of the calcium sensing receptor is in adjusting calcium levels. There's possibility that it could cause an increase in PTH, an increase in calcitriol production even without PTH, that it could affect bone turnover, and have an impact on other mineral-related measures. So again, this is my bucket theory, and our hope is that encaleret will be like that final bucket where encaleret will prevent the leakiness of kidneys and increase calcium while decreasing blood calcium while decreasing urinary calcium. So as a summary, the treatment of hypoparathyroidism with calcium and calcitriol can require a trade-off between blood and urinary calcium. Calcilytics, by decreasing urinary calcium loss, may allow for higher blood calcium levels without raising the urinary calcium. And they also have the potential to provide an exciting new oral therapy for people with post-surgical hypoparathyroidism. And we're currently recruiting, so thank you so much. And I'm going to pass the baton to Dr. Lionakis, who's going to talk about his work at in APSED.
Well, thank you very much to the organizers and especially Rachel for including me in this program. So I'm an infectious disease trained physician and I'm an immunologist. So I've learned a lot of endocrinology through the last decade with this disease, but this is a disease that is an autoimmune disease. That means our own body attacks its own, and that includes the parathyroid. There are a couple of important differences compared to the diseases we just heard. As opposed to ADH1, there is no parathyroid gland in these patients that can be boosted in order to produce more. And as opposed to the surgical hypoparathyroidism, the cause of the disease here is immune cells that are otherwise built in our bodies to fight infections. In this particular case, don't distinguish between our own self and outside invaders, and as a result, the disease actually is caused by our own body attacking it. And in this particular case, as opposed to what we just heard earlier, this is a syndrome. So it causes parathyroid decrease in about 75% of the patients, but patients who suffer from APS1 or otherwise called APSED can suffer from over 30 different disease manifestations that include both endocrine tissues and non-endocrine tissues. So I'll give you a short version of a journey that started about 10 years ago that has led us now to understand the disease and offer an immune-based therapy in this particular set of disease that calms down that inflammation that is otherwise attacking these patients' own body to offer treatment for them. Now, we heard earlier about autosomal dominant disease. This is a recessive syndrome. It means you have to have two different mutations, typically inherited from both of your parents who are otherwise asymptomatic, or as we heard from Kelly earlier, you can also have de novo development of some of these mutations. What's very interesting about this syndrome is it causes a lot of autoimmunity in many parts of the body, and also it causes a mucosal fungal infection, which was really the reason why I initially got very interested in it as an immunologist and an infectious disease expert. And this is a disease that has a very characteristic classic called triad of manifestations, which includes this fungal infection called candidiasis, parathyroid deficiency in about 75–80% of the patients, and adrenal insufficiency. So quite characteristic. This is called a classic triad. Having two out of these three clinically is used to make a diagnosis. Now, in very, very simple terms, we all make cells in our bone marrow that are called lymphocytes. They then go to the thymus in order to get educated to respond to bacterial, fungal, viral challenges, and that's why we all get protected from infections. But at the same time, those T cells, they need to learn that any cell in our body should not be subject to attack like a virus or a bacterium. And that gene that's defective in these patients called AIR is exactly what it does in all of us. It makes our immune system recognize those what we call self-reactive T cells that inadvertently develop in all of us in order to not get out of the thymus, go in the parathyroid or in the adrenal or in any other gland, infiltrate and cause tissue injury. So these patients don't have this proof-free mechanism, if you will, and as a result of that, they develop lymphocytic infiltration in many organs, including the parathyroid, that causes tissue destruction and the symptoms that they develop. Now, this is the NIH Clinical Center, where when about 10 years ago, I decided to start studying this disease, we took an approach that we felt at the time and paid off 10 years down the line of understanding every aspect of this disease. So as opposed to me only focusing, let's say, on their fungal susceptibility and not learn anything else about the disease, we assembled a team of physicians and scientists that spans 10 different NIH institutes so that when the patients come, they get evaluated as a whole and not only on what their primary or secondary complaint at that given time might be. This is the team from my group through the years that have worked clinically or at the bench, and what I'm showing you today is going to be their work. What this means is that patients typically come at NIH for an entire week where they undergo a very systematic clinical evaluation that includes the same physicians through the last decade. They all undergo whole genome sequencing, and they have a very uniform clinical, laboratory, and imaging workup that is tailored to the common and uncommon components of this syndrome, including parathyroid. And then when we do procedures for them, we try to understand clinically how to help them, but also made use of those to understand at the research level how this disease might manifest it, which has led to the insights that I'm going to share you in the next 10 minutes. So we've seen now close to 200 patients. We heard earlier ADH1 being in about 70,000 patients. It's probably individuals in this country. It's probably around the same for APS1, so still a rare disease, but probably a few thousands of these individuals in the United States. And what was very apparent as we were going through this very systematic approach is you can see on the very left side, hypoparathyroidism being at the top, candida and enamel hypoplasia, but you can also see these bars that marked in black that highlight diseases that these patients suffer in high frequencies that they were poorly understood or poorly recognized in the past. from enteritis. This is very important because about 80% of the patients cannot actually absorb even calcium and calcitriol when they develop hypoparathyroidism. Hepatitis, stomach, lung, skin, and salivary gland inflammation. The classic triad is depicted on the left. We developed what we now call an adjunct triad on the basis of our workup, that we feel that if it's combined with a classic triad, can actually lead to earlier diagnosis. And we've actually seen that now in more than one data set. This is the first data set where when we combine these adjunct triads with the classic triad, patients can be diagnosed 4 or 5 years earlier, so about half of the time that it would usually take until they reach an endocrinologist. Endocrinologists are quite savvy to realize that this is APS1. Non-endocrinologists, not so much. So what that literally has led into about half of the patients potentially could have been diagnosed before presenting with life-threatening endocrinopathies, including hypocalcemic seizures we heard earlier. This has implications from both non-endocrinological colleagues being able to recognize this disease early, and it has major implications for management, from calcium monitoring to ACTH stimulation testing to what I'll show you in a minute. If we can treat the disease, already established disease, can we actually intervene early to prevent the development of the disease? Now, I'm going to end on how we now can treat effectively in an immunological manner of this disease by summarizing here a paper we published 2 years ago that actually gave us a window of looking into this particular interferon axis that I'll elaborate in a minute, through actually the lens of why these patients develop mucosal Candida infections, the fungal disease that is very characteristic in them. And that work was based on the premise that, as I mentioned earlier, these T cells that we all eliminate when they react to our own, in these patients, they go out, they identify areas in endocrine glands, in non-endocrine glands, and they cause disease. It turns out that one of the major features of what these lymphocytes make is an interferon called interferon gamma. Interferon gamma is an important molecule in our immune system that when it's produced in normal amounts, it protects all of us from viral and bacterial infections. In this particular disease, there is an excess production of interferon gamma, which actually is the reason why these mice in this particular slide and patients develop mucosal fungal disease. That opened the window of looking at whether that excess interferon gamma that is produced by air knockout deficient cells is true for also other organs. And here is data showing interferon gamma excess production in T cells from mouse pancreas, salivary glands, and lungs. We've now looked at 8 different tissues, including endocrine tissues, ovaries, and parathyroid and thyroid disease glands. And for a simple depiction of how this important molecule acts, interferon gamma binds on its receptor. There are 2 molecules called JAK1, JAK2, just immediately after that. They're actually the target of FDA-approved drugs that are called JAK inhibitors. Downstream of that, you see a molecule called STAT1 that gets phosphorylated when you have activation of this signaling. And then molecules downstream of that are acting to protect against viral infections in the normal state, but in this particular case, when you have excess interferon gamma, autoimmunity can ensue. So what this shows on the right, it's a busy slide, shows that all of that interferon gamma axis gets fully activated in multiple tissues in mice that suffer from this syndrome. So can we use the JAK1, JAK2 inhibitors that are right there in the center underneath interferon gamma to change the history of this disease initially in mice? The answer is yes. On the right, you see a Kaplan-Meier graph of survival of mice that will not be treated, or they all succumb to the autoimmunity, and you look at ruxolitinib-treated mice, all survive. That is because they don't get autoimmunity anymore. So you see all of these purple collections of immune cells that are the lymphocytes that infiltrate in organs of mice that don't have air. And on the right side of the lungs and the salivary glands, you see no lymphocytic infiltration. That applies to all tissues. And that's because these lymphocytes that are marked here in brown are not present anymore. So an elimination of these lymphocytes that cause the autoimmune tissue destruction. Now, mice are mice. Humans are far more important. So we head to humans, and when we looked in the serum of patients, this is about 110 patients now with APOSET, interferon gamma excess is actually the most highly upregulated signature in the blood of these patients. We've now gone to develop methods in the lab to evaluate this pathway, not in mice, but in humans. All of the brown that you see on the left panels is stomach, on the right is lung for interferon gamma, for STAT1 and CXCL9. All of this brown doesn't belong in healthy tissues. It's abundant in patient tissues that have autoimmunity. We've now looked at 12 different tissues that correspond to autoimmune manifestations in these patients. So as in mice, APS1 patients also feature excess interferon gamma. So 5 years ago, we started treating these patients, initially off-label, now, as I'll show you in a minute, in a phase 2 IRB-approved protocol. This is patient 1 who had alopecia restoration. Her Sjogren's syndrome resolved. This woman had so severe enteritis that would require 15 laxatives a week to have a bowel movement, had rectal prolapse because of that, and required surgical intervention twice, went to have normal bowel movements, and had full restoration of her autoimmune manifestations. Patient 2, highlights from him, had a lot of Candida episodes, 3, as you see here, per year, complete elimination of those while he was on ruxolitinib. In his case, he had severe gastritis. When a gastroenterologist goes and does an endoscopy, on the left side, you see the outline of the red blood vessels. This is because the stomach mucosa is so thin from the inflammation that you can see the outline of the vessels. On the right side, you see the normal pink-looking epithelium because of the inflammation being gone. Related to endocrine signals that we've seen, actually one of the patients who was not always very compliant with his thyroid replacement, and as a result of that, he would have elevations in TSH before having ruxolitinib when he wouldn't be compliant, ended up actually self-stopping levothyroxine, and for the 3 years now that he's been on ruxolitinib, his TSH is normal. And the most recent patient actually we've treated had no menses for several years, has normal menstrual periods now with a hormone called anti-Müllerian hormone that is produced by ovaries, was absent and now increasing every time that we measure it. And last but not least, these patients have severe enteritis. I mentioned earlier about the constipation, but many of them have 12, 15 bowel movements a day. That complicates their hypoparathyroidism treatment. Many times they have to go to the hospital, as Rachel mentioned earlier, for a GI illness. These patients actually, many times it's the norm for them, that every month or every 2 months they will go because they just cannot absorb. So that leads to very erratic calcium or calcitriol or PTH dosing. So when they get into ruxolitinib treatment, you can see here, besides the alopecia restoration, this boy had restoration of his bowel movements, doubling his weight, normal levels of calcium, calcitriol in his particular case. So what we've seen now in the first 10 patients that we've treated is a remission in 14 autoimmune manifestations, from Candida to alopecia to nail dystrophy, gastritis, enteritis, pneumonitis, hepatitis, arthritis, salivary gland inflammation, thyroiditis, urticaria, pernicious anemia, exocrine pancreatic insufficiency, and primary ovarian failure, which is very encouraging and promising to us. It has really changed the life of these individuals. That has led us to now have a formal IRB-approved phase 2 clinical trial that has enrolled already 5 patients with a total target of 17. And while we have now, I think, shown, at least in these first patients, that all of them respond when they have already established disease, the important next question that comes directly to hypoparathyroidism here, because hypoparathyroidism, when it develops in these patients, you wouldn't expect it to resolve. The same thing with adrenal insufficiency. You see the intact PTH levels or cortisol levels be completely undetectable. But can we prevent the disease? That's an important question that we don't have an answer yet, but we are actually starting to try to answer this. So this is a boy we just saw at NIH just 2 weeks ago from Philadelphia, a 2-year-old boy with air deficiency, has had this APOSET rash, has Candida and hepatitis developing way before any endocrinopathy. And while his intact PTH has been now monitoring, monitored and was normal up to maybe 3 months ago in the 30s, the last 3 months has been in the 8 to 12 range repeatedly, indicating that in the next few months, this boy is probably going to develop autoimmune hypoparathyroidism. Now, if we would wait for that to develop and then come later and try to treat it, it's likely this is going to be not reversible, but we might have a window of opportunity while this is still operational as a parathyroid gland to reverse it. So we are going to start preemptive ruxolitinib in this patient. There is another patient we have who has glucose intolerance, so doesn't yet have diabetes, but in the next few months is going to develop autoimmune diabetes, who we are doing the same, in hopes of understanding whether we can treat disease when it's well established, but also take care of disease before it develops, especially for some of these endocrinopathies that you wouldn't expect to be reversed at that time. With that, I'd like to thank you, and I'll be happy to take any questions along with everybody else.
So if you have any questions, if you just want to raise your hand, we'll run around and give you a mic. Okay, here we go.
Hi, Dr. Gafni, you had spoken about the Enclara range of dosing being highly variable. I was curious if there's a correlation between severity of symptoms and dosing needed.
That's a really great question. So we did not see any correlation between the dose requirement and the symptoms or even the dose of calcium and calcitriol that they were requiring before they went into the study. We couldn't really see any relationship. What was definitely suggestive was, I told you it was 13 different patients with 9 different calcium sensing receptor variants. And so the patients who had the same calcium sensing receptor variant needed around the same dose. So it may be more related to the genetics. What we don't know for sure, though, is all of the patients where we had more than one person with the same variant, they were related. So a father and a daughter, or a cousin and cousins, or sisters. So there could have been another genetic reason why they needed similar doses, but we highly suspect it's related to the actual variant that is determining what kind of dose. And so with this larger phase 3 international study, we're hoping to enroll unrelated people who have the same variant, and that will help answer that question, as well as some laboratory studies in cells that might give us more information about that.
Thank you. Who else has questions?
This question is for Dr. Lionakis. I'm a physician. So my question is, do you see a correlation in these JAK overexpression in other urticarial or mastocytosis diseases or like histiocytosis diseases? Because we have a whole lot of them in the endocrine space, right, where you have people with one autoimmune disease and then they have all these other sort of urticarial complaints. That's kind of part one of my question. The second part is, do you think these likely represent variants of the AIR mutation?
Great questions. So I do not know the answer to the first question because we haven't studied those patients. As you might know, JAK inhibitors recently got FDA labels for atopic dermatitis. So in one of the patients who had autoimmune urticaria, we also saw complete remission. So in disease where there is an autoimmune urticaria, whether it's come from air deficiency or from other etiologies, there might be a role for those. I would say for other autoimmune endocrinopathies, APS2, APS3 perhaps, there might be common pathways that could be applicable, but unless we do the studies, I think it will be difficult to be for sure. I think the key message here, if I can say, is that these are diseases, APS1 for sure, and I suspect others, that there might be ways to actually act in a personalized manner and a treatment mechanism approach, and not only replace what is missing, which is an important element as well, but I think there's a window here where some of those diseases might be treated with something that addresses the problem as a whole, and hopefully early on. Now, I don't know if those patients would likely not have AIR biallelic variants, because then they would be expected to have this. But now there are patients who have been reported to have monoallelic AR variants, so being heterozygous, for certain variants that cause a little bit more abnormality than what you would expect of 50% for a heterozygous, without getting into too technical details, dominant negative mutations. And some of them have been reported now to just cause one disease, like vitiligo or pernicious anemia, or urticaria. So I think if there is a cohort of those, it would be useful to see whether they may carry variants in AR or other genes that might influence the phenotypic expression.
There was a question up front.
Hi, my name's John. Just curious, post-surgical hypoparathyroidism, it doesn't necessarily manifest itself till some time after surgery. And so it seems to me you could have damaged parathyroids. There's something left where they stop entirely. Is there a way of discerning what the status of the parathyroid is, whether it's, because some people it's severe, others it's not severe?
Yeah, hello? Yeah. Yeah, that's an interesting question. I think what we do know is that, what we can monitor is people's PTH levels and calcium levels. And some people with post-surgical hypoparathyroidism may have extremely low PTH, and there may be some improvement. And other people, have maybe a little, like just insufficiency, right? Like their PTH can go up to 20, but it can't go any higher. And so I think it really depends, but we can't really, see in the tissue, like what can, come back. It's hard to predict what can come back. I think the general teaching is after 1 year, probably it won't, that's when we consider it permanent, that it won't come back. But I've had patients who have, over time, the PTH started to go up a little bit over years or decades, So I think it's really hard to predict. It's hard to study in a really small, rare disease. But it's definitely something that I think is interesting. And, we'll see whether these glands that do remain can still be stimulated to produce even more PTH or not.
Yes, I have a couple questions from online guests. One is, if a patient has an auto transplant of the remaining parathyroid tissue, is it possible that encaleret may motivate the tissue to begin working or work more effectively?
I think it's possible. It's hard to know. I think it depends. So there's two possibilities. Again, we don't have the data for the study, so I can't really talk to whether it would work. But when I thought about what to consider, there's two possibilities. One is that the parathyroid glands that are there right now are working as hard as they possibly can, right? Otherwise, they would get your calcium up, right? But they're working as hard as they possibly can at this moment, and they can't work any harder. And even if we make them think that your calcium level is 4, they can't make any more, right? So that's one possibility. The other possibility is that, if they're really stimulated, that they could produce a little bit more. I think it's probably less likely for them to be able to be stimulated to make even more, but I think it's still an open question.
And the next question online is, does calcilytics suppress existing remnant parathyroid tissue function like parathyroid analogs do?
Oh, yeah, so no. So calcilytics actually do not suppress parathyroid function. So they actually stimulate parathyroids to produce PTH.
Okay, and I have one more online right now. They would love to discuss the APS realm with Dr. Lionakis more specifically, as they don't fit into any of the APS boxes. Is it possible to get contact info?
Yes, of course.
And one more just popped up, and then we'll see if we have any more from the audience. If someone could up there could just speak to as how do they sign up for the encaleret study, either both the post-surgical, or is there still an opportunity to sign up for the ADH1 study?
Yes, so I think the Hypoparathyroidism Association may have links to those studies on their website. The other way to look up any clinical trial is clinicaltrials.gov. If you go to that website and you just search either the name of the drug or the disease, you can find any of the studies, any studies that are recruiting, in the entire United States. So it can, that's a really good way to find out if any studies are related to you.
Hi, I'm a patient, a post-surgical patient with hypopara, and I was actually just wondering if there's a link that's been associated or if it's being studied perhaps between, regardless of how you acquire or if you're born with hypopara, if there is a link between malabsorption and the condition.
So hypoparathyroidism is associated with a decrease in calcitriol, and calcitriol is really important in increasing the absorption of calcium. So there's definitely, a link in that way. So if you have hypoparathyroidism, you're not going to be able to absorb calcium as well unless you're given calcitriol.
But I would add, most people who have neck surgery or thyroid surgery, it's usually either thyroid cancer or it's autoimmune thyroid disease. So Hashimoto's hypothyroidism or Graves' disease, and they're both autoimmune diseases. So it's not uncommon for patients with post-surgical hypoparathyroidism that had a primary autoimmune thyroid problem to have another autoimmune disease. So I've seen patients with Graves' disease who then have celiac disease and they have difficulty absorbing vitamin D or other issues. Or I've had patients that have had, B12 deficiency or something else. So certainly the thyroid, the autoimmune thyroid disease can cluster with other autoimmune diseases that can affect malabsorption.
Hi, I'm Lynn Kohlmeyer. Thank you so much. That was fantastic. I'm so happy to be here and meet everybody. I have a question about our partial hypopara patients that may not meet criteria for the trials for PTH. It seems like this would be perfect if you think it would work to use a calciolytic in somebody with, let's say their PTH is 25 when their calcium's 8 and they're still having symptoms and on calcium and active D, but we need to help.
Yeah, I think if the urinary calcium can be, the hypercalciuria of the high urine calcium can be ameliorated with a calcilytic in somebody with another form of hypoparathyroidism, maybe that means that it would be okay to run their blood calcium level at a higher, more really in the normal range, so they're not symptomatic either with parathyroid hormone injection therapy or calcium or calcitriol, because as I'm sure many of you know, that even when you're on these treatments, you still tend to have to run the calcium low, and you still have to tolerate some symptoms. So if there were a way to use a calcilytic as adjunct therapy, even if you can't get the blood calcium perfect with a calcilytic, maybe you could still get it. You could run it higher because you wouldn't have the renal effects.
I have another question from online real quick. They want to know the slide that was about the skull that was in, the bone was enlarged. Does that only apply to patients who have ADH1, or is this something also that post-surgical patients could experience?
I don't think we know the answer to that because I don't believe that, head imaging was done systematically in any of the PTH treatment trials. But we do know that intermittent injections of PTH 1 to 34 or 1 to 84 do have this sort of mixed effect on the skeleton, where in some parts of the skeleton the bone density will increase and in other parts the bone density will decrease, and we see these high bone turnover markers. So we're not sure how clinically relevant that is, because it doesn't seem to be causing more fractures or anything clinically relevant. These are just things that we're seeing on the bone density studies. We don't know that the change in the skull is clinically significant. We just know that we're not seeing a physiologic change in the skeleton with these short-acting PTH analogs. And that's why, and we'll talk a lot, you're going to hear a lot about long-acting PTH analogs, and certainly being able to get things more physiologic, the way your parathyroids would work normally, is going to be better for the skeleton in the long term.
All right. Well, thank you so much to the NIH team. We're so excited that you guys have been here, answered all the questions, and the continued work that you guys do every day. We really do appreciate it. Thank you so much. Let's give it up for NIH. All right, and then we're going to take a 15-minute break, so we'll be back in the room at about 11:45.